joined us. Member of many international affiliations, and he is a quite knowledgeable, very good walker, and he is a driving force of our active scientific program. And Dr. Manas Prithviraj M. from Gorakhpur, he is Associate Professor of Department of Psychiatry, AIIMS Gorakhpur, Life Fellow of IPS, member panel of Subject Expert Committee in Central Drug Standard Control Organization, New Delhi, guest associate editor in Asia Psychiatry, Specialty Section of Frontiers in Psychiatry. Areas of interest: child and adolescent mental health, OCD, and mood disorders in elderly. Resource person in the various state and national level, shaming and workshops. Welcome, Dr. Manoj. Welcome, Dr. Biswaranjan Misra. Now the meeting is over to the chairpersons. Kindly one of you will introduce the speaker and the other introduce the topic. Let us proceed. And from here on, the stage is yours. And before I leave, Happy New Year to everyone. And let this year be full of prosperity and progress for you. And
one thing I wanted to add. Somebody very close relative of Biswaranjan sir is seriously ill. He's most probably is joined in from the hospital. So it's a wonderful gesture from Dr. Biswaranjan to join in from the hospital also. It's sir. Over to the chairpersons now.
So good evening all, and wish you a very happy New Year. And congratulations to the entire team for the 125th Thursday Musing. This is a privilege for us to listen to one of the stalwarts in child psychiatry, Professor Shekhar Seshadri, who doesn't need any introduction. The topic that was, the topic appeared a little complex to me to understand, but whatever I could infer from the theme, it is related to the diagnosis per se and the overdiagnosis related to ADHD and related disorders. It's a very pertinent topic, can be best enlightened by Professor Seshadri. Age-related hyperactivity, at times it's very difficult to distinguish age-related hyperactivity from ADHD, and what should be the exact cutoff, or what should be the exact age in years from which we can really diagnose it. And over the COVID pandemic, we had seen the misery of the children with the lockdown and their internet addiction and lack of socialization. So there has been an issue of environmental understimulation also, which has made an increase in certain hyperactive and behavioral issues in the children. So with this, this is a topic which we need to understand. Are we overdiagnosing or underdiagnosing? What should be the cutoff and what should be the criteria? What should be our clinical approach step by step if we see a child with presenting with hyperactivity, particularly in this scenario? With these words, I would like to request our next chairperson to speak a few words about the topic, and after that, it's over to Professor Seshadri. Thank you.
Thank you, sir, and good evening to all dignitaries, and wishing a very happy New Year to everyone once again. Again, thanks for the team for giving me the opportunity to chair this session. So as Sir Mishra sir mentioned, nowadays now in our OPD also we are seeing a lot of children, particularly over the start of this pandemic, a lot of behavioral disorders in particular, particularly presenting hyperactivity, irritability, impulsivity. So there are high chances that these children may easily get with attention deficit and hyperactivity very easily when they visit the general physicians or pediatricians. And the parents' interest and the parents' curiosity to know change in the behavior also significantly matters a lot. They wanted to get their children get better at any cost, and so the of these children to get overdiagnosed is always there. In this background, today's topic is very relevant, and we have with us Dr. Shekhar Seshadri sir, the stalwart in this field. And so without wasting much of the time, I would invite Sir to proceed with his presentation and enlighten us. Thank you.
Thank you very much. If I may be allowed access to slide share, please. Thank you very much. सबको नववर्ष की शुभकामनाएं. I think can I request people to put their mics on mute, please? Thank you. Thank you. As Manoj and Vishwaranjan have pointed out, ये आज का सत्र जो है 125वां Thursday Musings का, and the first of 2023 as a prelude to what we hope is a wonderful ansips that Tufan and Amrit and the team there will organize for us in Bhubaneswar, and we're all looking forward to that. Now, Manoj and Bishu have actually laid two parts of the framework of what I want to present to you. And, you know, as Alim pointed out, topic जो था वो थोड़ा complex लग रहा था, थोड़ा intriguing लग रहा था. अब इस बात का मैं थोड़ा स्पष्टीकरण करना चाहता हूं आपके लिए. I would like to start the new year. When I say let's start the new year with frameworks, one of the limitations, shall I say, of the practice of clinical psychiatry has been this preoccupation with diagnosis and with classificatory systems. I have nothing against diagnosis and classificatory systems. I believe they are important, they are academic, they are scholarly, and they are relevant for diagnostic purposes and for putting treatment. But somewhere I think we have forgotten the social context of mental, behavioral, and addictive disorders. And the reason why I have selected ADHD as a metaphor is because of the kind of heterotypic continuity it has as you look at it from a life cycle perspective. Let me give you two examples of what I mean. 11 महीने का बच्चा है, 11-month-old child. Significant sleep rhythm disturbances. Too early to diagnose ADHD, lot of parenting issues. Parents by temperament themselves are anxious, perhaps obsessive, in the presumption that the sleep problems is being caused by the ecology of where they stay. Rooms are changed, houses are changed, the father doesn't sleep, the mother doesn't sleep, their sleep rhythm cycles go awry, they get into issues of irritability, there is problem in job and in interpersonal relationship. This escalates into a marital issue and into other pathology from what primarily started with perhaps the latent beginnings of a form, fructe as we call it, of preschool ADHD. अब ये sleep rhythm cycle को लेके एक बच्चे के परिवार में क्या बीतता है by the time they actually come for consultation. All this is best if you look at it purely from a classificatory perspective. Let me give you another example. Young adult, a gentleman, long-standing, perhaps difficult temperament and personality, perhaps cantankerous, perhaps difficult to manage with challenging behaviors in the growing process. Some tendency towards psychoticism, has a breakdown, predominantly paranoid ideation, alienated from the family, relocates to another city, not too many social supports there. Some of the family supports because of earlier tense relationship, they are not in touch and therefore not part of the social system and network of this individual. The manifestations of what is later diagnosed as paranoid disorders is arousal symptoms and a lot of overactivity. And then there is a crisis and an admission takes place. And who is to come and assist this person, because there is no other support system. It's a new city. The family is unwilling or unable to come or not contactable. There are issues of finances. Who's going to pay for the hospitalization? How long will the hospitalization take place? And if the paranoid ideation actually escalates and gets into stuff like computer is being hacked and phone is being hacked and so on, and complaints are made and social systems move in. So you see how a primary manifestation started with a young adult who was overactive with no clear diagnosable symptoms, and then somewhere it escalates into a picture which conventional clinic-based practice will not address. And this, friends, is what I want to present to you as a framework to start this new year, in the hope and the plea that in our teaching, in our scholarship, in our clinical work, whether we are in academics or whether we are in practice, whether we are in corporate hospitals or teaching hospitals, whether we are nursing homes or whether we do solo practice, how do we keep this framework in mind, two parts of which in terms of the challenges of early diagnosis and the challenges of comorbidity the chairpersons have already alluded to. Having said this, I would like to present to you a small clip, and let's share this with you. And
बारे में जरूर कुछ बताइए।
क्या है कि जो हमारी फील्ड है साइको एनालिसिस, ये यूरोप में पैदा हुई और इंग्लैंड और अमेरिका और लैटिन अमेरिका में पली बढ़ी। इसके फाउंडर थे सिगमंड फ्रॉइड साहब। जब साइको एनालिसिस दूसरे मुल्कों में गई, दूसरे मुल्कों के लोग दाखिल हुए। शुरू में सारे यहूदी थे, फिर उसमें क्रिश्चियन आए, फिर उसमें हिंदू आए, मुसलमान आए, पारसी आए, सरदार आए। तो नतीजे के तौर पे चीनी, जापानी आए, कोरियन। तो जब एक नया कल्चर आना शुरू हुआ दोनों लेवल्स पे, मरीज़ों के लेवल पे और डॉक्टरों के लेवल पे एक, और जब बच्चों को देखना शुरू किया, सीरियस बीमार बच्चों को बल्कि हेल्दी बच्चों को, तो नॉलेज बढ़ी। तो फिर मुझे ये ख्याल आया कि इसमें हिंदुस्तान कहाँ है, इस फील्ड में हिंदुस्तान भी होना चाहिए। और हिंदुस्तान में बच्चा कैसे पलता है, अमेरिका में बच्चा कैसे पलता है, वो एक बात नहीं है। तो जाहिर फिर उसका दिमाग डिफरेंट बनेगा, उसके फिर किस चीज़ को बीमारी कहेंगे। तो जैसे कि मैं जानता हूँ यहाँ हिंदुस्तानी दोस्तों को, ख़ास तौर पे औरतें, मैं कई हिंदुस्तानी औरतों को जानता हूँ जिनकी माएँ रहती हैं इंडिया में, लेकिन वो उन्हें रोज़ फ़ोन करती हैं। तो नतीजे के तौर पे ये बात अमेरिका में गोरे आदमी में, पढ़े लिखे गोरे आदमी में समझेंगे कि औरत तो बीमार है। माँ से इतनी क्या मोहब्बत, मियाँ से करो मोहब्बत, और माँ से इतना क्या अटैचमेंट, ये पागल हो गई, ये रोज़ ही फ़ोन कर रही हो। तो इस किस्म की बातें, या ये कि समझते हैं कि बच्चे को कितने दिन तक गोद में रखना चाहिए, बच्चा माँ बाप के कमरे में सो सकता है या नहीं। तो हल्के हल्के उसके असरात क्या पड़ेंगे, पॉजिटिव एंड नेगेटिव। हर चीज़ देखिए, दुनिया में मेरे भाई का एक शेर है जिसमें एक मिसरा है कि शेर ये है कि गम होते हैं जहाँ ज़ियानत होती है, दुनिया में हर शय की कीमत होती है।
जी।
तो उसी तरह से बच्चे का अलग कमरे में सोना बहुत जल्दी, उसके फ़ायदे भी हैं, नुकसान भी हैं। बच्चे का माँ बाप का साथ सोने में भी फ़ायदे भी नुकसान है। निदा साहब ने कहा है ना, कभी किसी को मुकम्मल जहाँ नहीं मिलता, कहीं ज़मीं तो कहीं आसमान नहीं मिलता। तो ये नहीं है कि वो अच्छा है या ये अच्छा है, फ़र्क है। तो मैंने वो फ़र्क के बारे में सोचना शुरू किया। तो शुरू में इतनी सोच समझ ज़्यादा नहीं थी, पढ़ाई इतनी ज़्यादा नहीं थी, तजुर्बा इतना वसी नहीं था। तो एक एडिटेड किताब छापी मैंने, फ्रॉइड अलॉन्ग गैंजेस, जिसमें मैंने कई लोगों को बुलाया कि इस मुख्तलिफ हिंदुस्तान के बारे में ख्यालात लिखें।
वाह।
मैंने भी लिखे। उसके बाद फिर मैंने एक बहुत बड़ा पेपर लिखा, जो कि अभी कोई 1-2 साल पहले, जो कि ज़्यादा इन्फॉर्म्ड है। उस पेपर का नाम है वेयर इज़ इंडिया इन माई साइकोएनालिटिक वर्क। तो वो पेपर जो है, क्योंकि जिस तरह से आपने शुरू में सवाल पूछा था, बहुत अच्छा कि शायरी और नफ्सियात की प्रैक्टिस में क्या रिश्ता और क्या दूरी और क़ुर्बत है। उसी तरह से हिंदुस्तान और अमेरिका में, मेरे अंदर जो एक हिंदुस्तानी आदमी और एक अमेरिकन डॉक्टर है, इन दोनों में क्या रिश्ता है। तो वो रिश्ता हल्के हल्के मर्ज हो गया और they became one.
That's
much more Indian.
One of the issues that I basically wanted to bring to your notice. That if you look at what Salman Akhtar is saying here in terms of the frameworks through which we think, make our diagnosis, overdiagnosis, as the case may be. And then we really look at the crux of what I would like to share with you. That if you look at attention deficit hyperactivity disorder, Janab Salman Akhtar referred to, sleeping issues, a woman who's hyper, and calling all the time, are you crazy? Why are you calling all the time? Why can't you be rested and still? So if you look at one of the latest JAMA systematic scoping reviews of almost 300 plus published studies in children and adolescents, friends, we have convincing evidence that ADHD is overdiagnosed in children and adolescents. Now, one can understand that for individuals with milder symptoms in particular, the harms that are associated with ADHD diagnosis may often outweigh the benefits. The question we have to ask ourselves, therefore, is whether it is children or whether it is adults, whether it is solo practice or group practice, nursing homes, larger hospitals, teaching hospitals, corporate hospitals, what kind of a system of diagnosis do we use, and how conscious are we in any diagnosis that we make for any individual as to the limits and the range of our thinking. And this is particularly important because if you look at the developmental trajectories of ADHD symptoms in large populations, ये भी काफी recent है, ये 2021 का है. We know that there is substantial heterogeneity in the developmental trajectories of ADHD, and which is why I said diagnosis, overdiagnosis, and heterotypic continuity. And we know that adult outcomes of ADHD, residual attention deficit, impulse control issues, mood disorder, substance use, sociopathy/psychopathy, the extent to which OCD and anxiety is comorbid with, I'm not even talking about adult outcomes, I'm talking about comorbidity now. So both in terms of developmental trajectories and adolescent adult outcomes, if you look at the kind of substantial heterogeneity that is there in this disorder, and if you really look at the UK Millennium Cohort study, where latent class growth analysis was applied to evaluate this developmental trajectory, there seem to be 6 kind of trajectories here. Almost a third of the sample are unaffected. A quarter mildly affected, about 10 to 12% subclinical but remitting. And then there is preschool with partially remitting, and then developmentally increasing, and then preschool onset and persisting. So if you look at really the group of people in which there is an increment of persistence, that's approximately about 14 to 15%. And this is important, friends, because distinguishing different trajectories of ADHD symptoms could be clinically informative. Or ADHD, I'm using only as an example. There are many other disorders in which the trajectories are very different. So my submission to you as we start this new year is to really look at our clinical work, not in terms of discrete diagnosis, however obvious they may be, but look at this whole latent class growth analysis and the kind of heterogeneity that is found in disorders. Let me take you next to the whole issue of what this means in quality of life and effectiveness and tolerability. This was the Quest study. This was about a decade old, but it's an important study because almost about 700 adults who received clinical diagnosis of any ADHD subtype, we can see that hyperactivity declines, but inattention remains significant, thus making the hyperactive impulsive subtype as defined by childhood criteria a very rare condition, and raising questions as to the validity of the hyperactive subtype in adults. Now, this is important because if you look at the course of attention deficit hyperactivity disorder over the lifespan, let's table a couple of things which are fairly clear. A, it is a neurodevelopmental disorder. B, for many years it was considered a typical childhood disorders. Long-term studies, though, showed that an important percentage did have adults with ADHD. And many people who work in the area of substance use, who work in the area of residual attention deficit, of the kind of social impairment that occurs in adulthood because of ADHD. Then we also know that the clinical picture varies with developmental stages. Remember, I spoke about the 11-month-old child with sleep rhythm disturbances. To preschoolers mein chunauti kya? So have a glance. What happens in preschool years? Excessive physical activity, difficulty in cooperation with peers, non-compliance. So you see a lot of social behaviors is what you'll find. In school age 6 to 12, apart from the nuclear symptoms, which is there in ICD-11 DSM-5, oppositional behavior, the overlap between conduct disorder, ADHD, and conflict with peers and academic problems. In adolescence, hyperactivity lessens, but there's conflict with parents. So interpersonal conflicts, risk behaviors begin to appear. And then in adults, the physical activity reduces while attention and impulsivity may still remain. If we then say that comorbid disorders are common and in most times continuing until adult life, and you look at the kind of variability, बचपन में अगर ODD है, oppositional defiant disorder, related to antisocial personality disorder in adults. Or if there are emotional disorders in children with ADHD, anxiety, OCD, which are quite common, they can be due to either common biological mechanisms or the long-standing effect of psychosocial and environmental factors which follow people with ADHD. And my submission to you, and this was the reason why I spoke about ADHD and the new normal, is particularly post-pandemic and the kind of attention span and screen time and all the other concerns that have been expressed, researched, written about. Notwithstanding that, the fact remains that psychosocial and environmental factors which follow people with ADHD have suffered short shrift as far as clinical evaluation and attention and management and interventions are concerned. And it is my plea to you, friends, as we enter this new year, that this must increasingly find its place other than robust clinical diagnosis, as well as judicious and planned use of medication where indicated. Couple of other things. The relationship between ADHD and substance use has been a subject of research. I did notice when I was just scrolling that my good friend Devashish Basu was also in today's session. Phenomenal amount of work has been done in the Center of Addiction Medicine in NIMHANS as well, with a view of the existence of conduct disorder being necessary for a person to present with substance use disorder currently prevailing. Now, does stimulant treatment in childhood offer some protective effect against drug use and alcoholism in adolescence? Does the diagnosis of borderline personality disorder, which is common in adults with ADHD, the overlap of the symptoms between two disorders? So the question is whether the diagnosis of borderline personality disorder is appropriate and useful in the presence of ADHD. Because when ADHD precedes the symptoms, I beg your pardon, and the impairment in functioning are due to this disorder. Not to mention OCD, mood disorder, explosive aggression. To state it in summary, when another diagnosis or several symptoms as a part of another disorder are also present, treatment of the primary disorder, that is ADHD, is beneficial and effective for all the presenting problems. 20 years ago, the Journal of the American Academy of Child and Adolescent Psychiatry actually published a special section on ADHD comorbidity and treatment outcomes. This was the famous MTA ADHD trial. And these findings still prevail, friends. What do they indicate? There are three clinical profiles: ADHD co-occurring with internalizing disorders, principally parent-reported anxiety, absent any concurrent disruptive disorders. So this is ADHD plus anxiety. Second, there is ADHD co-occurring with oppositional defined conduct disorder, but no anxiety. So this is ADHD plus ODD-CD. And third, ADHD with both anxiety and externalizing disorders. Now these three profiles may be sufficiently distinct to warrant classification as ADHD subtypes different from pure ADHD with neither comorbidity. And my submission to you is, going ahead, as we enter a new era, a new year, a new pattern of thinking, new frameworks, the new normal, all our clinical, etiological, and genetic research should explore the merits of these three ADHD classification options. Some other thoughts to share with you. Pay close attention to this slide and think back to what I said about that adult presenting with arousal symptoms and agitation, but basically alienated from the family, staying in a new place without any social supports, and getting into trouble with the authority. And how do you diagnose something which on the face of it appears to be just agitation and overactivity and restlessness there? If you look at the whole age issue here and some of the key stages, and you look at what happens in younger age as opposed to older age groups, and you look at a staging pattern of ADHD and the kind of impact in the lower age group that children with only ADHD have on the kind of experiences of self-esteem. बैठता नहीं है, हरकत करता है, कभी नहीं सुधरेगा. It's because of you that we are facing difficulties, peer rejection, unpopular in class, unpopular in social situations, and what that therefore does to a child's self-esteem. And what is the extent to which in our evaluation we really look at these dimensions as opposed to the clinical dimensions of the primary disorder. If you look at somewhat older children and at a third stage, so I'm not talking about the preschool age group here, I'm talking about somewhat older age group. So stage one, the key stage one would be preschoolers. If you look at stage three, look at the kind of impact it has on social skills, on learning delays, and on the presence of disruptive externalizing behaviors, or what is generally called as disruptive behavior disorders. And at the fourth stage, during pre-adolescence, adolescence, and youth and adulthood, the whole complexity of criminal behaviors, challenging behaviors, defined behaviors, exclusion from social systems, substance abuse, conduct disorder, motivational dynamics, and complex learning difficulties. So how, therefore, whether you're working with children or whether you're working with adults, whether you're working in a predominantly substance use disorder facility, or whether you're working with people who have mood disorder, OCD, anxiety, but you suspect may have residual ADHD, how in your staging of ADHD and age, you look at all these dimensions so that when you look at the kind of heterotypic heterogeneity in the presentation and the heterotypic continuities that or discontinuity in this case as it exists in ADHD, our clinical approach needs to take all these into consideration. And our approach, therefore, is not just pharmacotherapeutic or pharmacogenomic, but it also takes into consideration psychosocial and psychotherapeutic interventions and learning and developmental interventions, social interventions that address this entire dimension of what happens in ADHD. Some final thoughts. If you look at the findings of the NIMH multimodal study, the MTA, which I alluded to earlier, what had happened was that way back in 1992, NIMH and 6 teams of investigators started this massive study. And there were almost 600 children who were randomly assigned either to community care. And one of 3 study treatments were delivered. Monthly medication management, usually stimulants, methylphenidate, intensive behavioral management, and a combination treatment. And children were assessed at 4 points of time in multiple outcomes. And the results indicated that the combined and medical management interventions were substantially superior to the behavioral management or the routine community care management. If you look at other functioning domains, social skills, academics, parent-child relationships, externalizing behaviors, anxiety, depressions, the results suggests slight advantage of the combination over single treatment in community care. Again, the evidence really points to the absence of psychosocial management in this entire rubric of presentations that are, and that's what combination treatment actually means. Therefore, high quality medication treatment, careful, adequate dosing, 3 times methylphenidate, atomoxetine, follow-up, school communication, ये तो ठीक है, ये तो कीजिए. But if you look at the overall study findings, the largest benefit for high quality medication, regardless of whether given in the medical management or the combination group, secondary analysis reveals कि ये combination जो है, it has a significant incremental effect over medication, particularly if you look at the categorical indicators of response. And when composite outcome measures are used, not just overactivity, not just attention, not just corners, but you look at composite outcome indicators. And composite measures are not necessarily a research issue, my friends. It is a clinical issue. And believe me that in good clinical practice, when a client, a patient sees the amount of care and interest that you have in their lives, and in their lives meaning in their self-esteem, in their learning experiences, in their socialization experiences, whether they got into trouble, whether they're included or excluded, are they struggling with impulsive behaviors, do they speak about motivation? And when you address these issues, the chances that the therapeutic alliance would be strengthened is substantially more. That was methylphenidate. The same actually holds even for atomoxetine. And if you look at the efficacy and safety of atomoxetine in pediatric ADHD, and if you look at a whole lot of meta-analysis of various double-blind RCTs, particularly if you calculate the standardized mean difference. And this is a fairly major study, across 25 RCTs. Again, short-term atomoxetine may be safe, may be superior to placebo in overall ADHD symptoms and key secondary symptoms with medium effect size. But a relevant patient subgroup continues to have significant symptomatology. Again, because merely giving medication is not enough. So सवाल ये उठता है, to end my presentation. If you look at heterotypic outcomes and discontinuities and long-term outcomes and comorbidity, secondary conditions, healthy risk behaviors, हम अपने आप से ये सवाल पूछें कि सबसे कीमती
Hello, hello. Am I not able to hear?
Sir, we lost sir maybe.
Achha, achha.
Let's wait for it.
I thought my connection was lost.
Your connection always lost. Sometimes Abhinav helps you to get it back in Lucknow. आगे sir, आगे. Sir, you are muted. Sir, you are muted. Sir, please unmute yourself and mute Alim sir.
I will mute myself. Sir, you go.
नहीं, I wanted to check कि कहाँ तक slides चल रही थी.
Question. जो आपने कहा था question, वो question के बाद we were lost.
ठीक है, अब ये सवाल दिख रहे हैं?
We are entering, sir. Yeah, visible.
This one.
ठीक है. And are there effective treatments for comorbidity or the prevention of secondary conditions? तो अगर आप करंट इंटरवेंशंस को देखें, जितनी भी कोमोबिड कंडीशंस हैं, साइकोफार्माकोलॉजिकल को तो सक्सेस को तो छोड़ ही दीजिए, लेकिन जब हम कॉम्बिनेशन थेरेपी की बात करते हैं, the focus of treatment for those individuals who present with significant comorbidity is placed on the antisocial rather than ADHD, which is often ignored. And this may be pertinent जब हम खास करके आजकल juvenile correctional setting, children in conflict with the law पे भी इतनी बात हो रही है, इतना चर्चा हो रहा है. But the issue, friends, is research to date has not addressed this question in terms of school performance, interpersonal relationships, job functioning, achievement, and adult ADHD, do have these difficulties. But it is not known if the current treatments in childhood relate to more positive outcomes in such areas of adult functioning. तो ये सबसे खास बात है फ्यूचर के लिए जो हमें नजर में रखना बहुत जरूरी है. And finally, if you look at the Center for Disease Control, the CDC, my child has been diagnosed as ADHD, और अब क्या करें? Now, what happens in preschoolers is what is recommended is parent training and behavior management is the first line, even before medication is tried for preschoolers. For 6 years and older, the recommendation may be medication and behavior therapy, parent training, management for children up to 12, and other types of therapy and training for adolescents. But schools must be part of the treatment, which means classroom interventions and school support. Young children have far more side effects to medication, and the long-term effects of ADHD medication in young children have not been well studied. Stimulants are the best known and most widely used ADHD medication. 70 से 80% बच्चों में with ADHD have fewer ADHD symptoms when taking these far. So this overdiagnosis and overmedication has become a huge problem. So we need to keep in mind that ADHD lasts into adulthood for about, as I said, for about a third of the children. But adults ke liye, it's not just medication. Like I said, in all the other areas of functioning as well, they need inputs. So rounding up, ADHD research ki nai findings, new studies, new insights. Unfortunately, DSM-5 currently does not include emotional symptoms, despite research indicating its importance. एक नया replication analysis आया है adults में, saying there are two subtypes, attentional and emotional, and this is something we need to keep in mind. There are alternative treatments, neurofeedback, which is non-pharmacological, which has come. There is a lot of translational research, particularly in the ICANN School of Medicine in Mount Sinai, with pharmacogenomics and functional imaging and psychiatric care. But ye imaging stimulant and non-stimulant treatments for ADHD, a network-based approach, neurobiological basis of response to wiring, and efficacy of lisdexamfetamine in adults with ADHD and sluggish cognitive tempo, ye SCT jo hai. These are some new areas that are emerging for those of research and academic bent of mind would keep in mind. Therefore, in evaluating non-stimulant alternatives for children, adolescents, adults, ye hai aapke liye. चाहे वो functional MRI से हमें पता लगे या pharmacogenomics से, we have both ways in which we have figured out that some of the molecules which some of them are norepinephrine reuptake inhibitors, some of them are alpha-2A adrenergic receptor agonists. So how these are increasingly being used? और बाकी हमारे IJP से जो क्लिनिकल प्रैक्टिस गाइडलाइंस जो आई थी कि कैसे जो दवाइयां हैं, फॉर्मुलेशन क्या है, स्टार्टिंग डोज क्या है, मैक्सिमम रेकमेंडेड डोज क्या है. But more than that, friends, this is the algorithm, and I will end with this. किसी भी व्यक्ति या बच्चे के साथ ADHD या हाइपर एक्टिविटी जो है, अगर हम डायग्नोज करें, how do we communicate that diagnosis, provide support to the family? Is the child less than 6 years? Yes. More? Not less than 6 years? More? Have psychosocial interventions been done? Is there a good response? If impairment persists, are there complicating factors or comorbidity? Parent training adherence kaisa hai? How do you maintain treatment in periodic review? If impairment persists, how do you do environmental modification, school liaison? Then you get into medication, and if ADHD is severe. On the other hand, for older children, what are the kind of environmental modifications? Is the impairment severe? And the same issue of parent training, stimulant medication, either atomoxetine or alpha-2 adrenergic agonists, and you look at good response and you review the diagnosis that. So this is the kind of algorithm that one has to follow to really look at the kind of approach that one needs to take. So let's start the new year with a framework, diagnosis, overdiagnosis, and heterotypic continuity, ADHD and the new normal. दोस्तों, ADHD सिर्फ उदाहरण था. मेरा प्रस्ताव, मेरी विनती आपके साथ ये है कि क्लिनिकल काम को एक नई दृष्टि और एक नए उत्साह के साथ शुरू करते हैं as we go into ANSIPS, to really re-examine our clinical work, our diagnostic processes in a way that we treat the individual, not the disorder. We address the social context and reality of the individual, not the symptoms. And we look at the subjectivity of the lived experience of human beings, and not necessarily the, the kind of research that necessarily informs it. Thank you very much for this attention. I wish all of you a very healthy and a happy new year. And I'm happy to spend some time in some discussion and questions. And I hand you over to the curators of Thursday Musings, as well as the chairpersons for their erudite observations.
Thank you so much, sir. Once again, you made our time worth it. Sir, actually, initially I was confused what we are going to do. Now, what I'm able to understand is keeping the bird's eye view and the microscopic along and the patient at heart. I think if we have these 2 points, most of the things are covered. Is that right? So, I think, yes, sir.
So I already see that there are some questions. I'll quickly answer them, yes, and then I will hand them over to the curators. There is a question from Bikram that there's been a rise in few teenagers demanding ADHD diagnosis when migrating to US and Canada. What's the privilege? My own suspicion, Bikram, that this has probably something to do with CBD. And CBD, which is the cannabinoid, the oil, has become one of the kind of treatments to. So, but this is a hypothesis. I have no means, to say this with any conviction. But this is something that we need to keep in mind. Your other question about how to certify ADHD as a disability. It's a question of kind of applying the same. See, ADHD comes with a lot of comorbidities. It comes with learning disability, it may be comorbid even with intellectual disability. So it's a question of what kind of scales you essentially apply to look at the kind of testing that needs to be done. And we follow the same parameters that have been recommended for the certification part. As far as Srividya's question is concerned about the efficacy of microdosing with psychedelics in case of adult ADHD, many of my clients seem to be using it. This is the related question to CBD, and I do know for a fact that many experimental treatments, not just for ADHD, but even for OCD, psilocybin, for example, is also being used. But this is really not, my area. And I confess that, Srividya, I do not have much reading as far as adult ADHD is concerned, particularly with these kind of experimental medication. But it's interesting that you have brought it up, because this is something that is likely to come to clinical attention more and more, particularly with those people who work in the area of substance use disorders. The question from Amina is, ADHD being a neurodevelopmental disorder, how long should we continue medication? Stimulants are very short acting, so should it be need-based, and can we take it at school, work, drug holidays, vagera? Now, these guidelines are very much there in the clinical practice guidelines. In fact, when methylphenidate first started, the whole issue of drug holidays was quite commonly practiced. And the reason for that is methylphenidate has a very short half-life, and you can actually give multiple doses, and it is required only when tasks for self-application are actually called for. Atomoxetine does not function in the same way. It has a different mechanism of action. But certainly with the anxiety and concern with preschool medication, that does it actually cause growth retardation, was an issue that was kept in mind. And one of the things that people often spoke about, if there was a 5 or a 6-year-old with such severe ADHD that he was hurting himself or simply not able to sit, and there was family history of tic disorder or something, and you didn't want to put the child on stimulants, then clonidine would have been a good alternative, because one of the advantages with clonidine is that clonidine actually stimulates growth hormone secretion and does not give rise to the kind of growth retardation issue that people spoke about where methylphenidate was concerned. And Sukriti's question about continuing medication into adulthood, absolutely. If you look at most people who work in substance use disorders in adult ADHD, methylphenidate and abuse potential notwithstanding, both methylphenidate and more recently atomoxetine is quite commonly used in adult ADHD. And adult ADHD is more and more being diagnosed in clinical setups. Sudeep's question about the COVID pandemic, confinement, lack of outdoor activity, screen time, parent exposure, rampant rise in the diagnosis of ADHD, whereas those were more with EBDs in their longitudinal course. And Sudeep says this is his personal experience. What Sudeep is reminding us of is the care that needs to be exercised in making a diagnosis of ADHD. The symptoms of ADHD must be present in more than one location. It cannot be just an offhand overactivity that is observed just at home, but nowhere else. So it must not be made only on a cross-sectional evaluation. It must not be made only on the basis of history that is available to you, only of overactivity observed in one location or one situation. And this is the point that Sudeep is making. And of course, Debashish's agreement in terms, but the question about a busy clinic, and of course the talk about music, which is my second passion. But yes, I appreciate Debu, the harsh reality sometimes in a busy clinic. But I do believe that when algorithms are followed, and this is something that I often say, that it is not that several sessions of an hour each are required to sort some of these issues of diagnostic nature, or even for complex therapeutic interventions. That it's a question, I think, of one or two initial sessions of robust evaluation by which you get a sense and a framework. And once the client and the family is aware that you're looking beyond the diagnosis and beyond medication, there is a certain receptivity then to the kind of approaches that one would look at. And now I see that a lot of issues have come up: ADHD adults and marital relationships, about concessions in the US, about how to assess intellectual disability in uncooperative children. So now there are behavioral indicators that, in fact, John, who currently heads the department in NIMHANS, has been part of a whole worldwide study which looks at behavioral indicators of intellectual disability, and not just psychometric indicators. That Kriti Jain speaks about universities that offer relaxation to ADHD, which is very true. Durvasi speaks about ADHD and ODD, who don't adhere to compliance. So parent management training of CASDN, the PPP program, which works in disruptive behavior disorders, that issues of children with ADHD and high IQ has been raised. The risk of substance abuse has been raised. And the issue of differentiating temperament and ADHD has been raised. People have asked about other molecules like carnosine, which now this is again, it's at the risk of saying that some of these molecules can have the risk of being fashionable unless they go through robust experimental design and so on. So that is something that we need to keep in mind. So the issue of temperament and adolescence, of adult ADHD, substance use, this is the whole framework of many issues that have come up, really making the point very strongly कि clinical practice में एक disorder को देखिए आप, ADHD, and see what is the kind of ramifications it has, and what are the kind of clinical challenges that you can face, which vitalize your work and also get you to a stage where you enjoy this kind of work and challenge that. And also to say that adult ADHD assessments के कई tools already available हैं. I may not have the resources right now to put it on chat because I do not work with adult ADHD, but this is just to let you know that now many tools are available for clinical assessment and systematic and objective assessment of adult ADHD. I think Janab Alim has already put something on chat. Janab Alim and Amrit, if you'd like to curate something before we hear from the chairpersons.
Yes, sir. So I think we should invite chairpersons and then take up a few more questions.
Surely.
If you allow. Yeah. Manoj bhai, any comments? We'll come
Thank you, sir.
for your final.
Thank you, sir. So I think the aura from the speaker himself and the topic per se itself, sir, has generated a lot of interest in the chat box. I could see a lot of questions coming up. I think it could endless be going on the questions. Sir, again, sir, thank you, sir, for the wonderful presentation. Sir, a few points to summarize or to note down, sir. So I just was going through a recent paper on the challenges and the probability of overdiagnosing ADHD, sir, as we're discussing. So in that interesting paper, 3 important points were discussed. What could be the probable reasons? One, they said, sir, it was the clinician's view, the parent's viewpoint, and as well as, sir, the changing socio-dynamics that of late we are undergoing through. So particularly, sir, we can see the last few it has been reported that the prevalence of ADHD has dramatically increased reporting-wise also. So nowadays children come with a variety of behavioral issues, and one of the common diagnoses is ADHD, because any child, if you see they're a little hyperactive, a little over-talkative, immediately the diagnosis goes towards ADHD. Unfortunately, where it should not go in that way very often. So my question is, sir, how to understand, like, in the change of maybe the pattern, how the children are growing up nowadays, exposure to screens, exposure to gadgets, and the family dynamics itself per se is also taking a deeper change by itself, sir. So in this viewpoint, how do you really see the making a diagnosis of ADHD, sir, from the parents' viewpoint also, and change in the family dynamics, as well as the children's exposure to electronic and screen time, those things, those aspects, sir?
Manoj, as I had pointed out, the combination of clinical history, see, what is the context of a parent bringing a child to a clinical consultation? Where has the threshold of tolerance been crossed? Is it a learning issue? Is it a behavioral issue? Is it a one-off incident, or is this something which has been pervasive over a period of time? Now, if you look at mild ADHD, exuberant children, and particularly those who have high IQ, they may not come into clinical context because they have social skills they're able to manage and so on. So the combination, therefore, of a robust history which looks at a behavior or a symptom not in isolation, but a certain pattern of behaviors conforming to the three domains which are mentioned both in our ICD and adjacent systems, which is overactivity, attention deficit, as well as impulsivity, and the 5 behavioral manifestations each. So a total of about 15 behavioral manifestations present over a period of time in more than one social context is what raises the suspicion that one is dealing with ADHD. Supplement that with your own observations, interactions, and the application of clinical scales. Supplement that with longitudinal follow-up, school report on classroom behaviors, and the kind of feedback that one has from the teachers and the peer group. When you put this together, you really reach a robust framework. हम जब framework की बात करते हैं, and I said, let's start the new year with a framework. Let's start the year with a new framework. This is exactly what I meant, that sometimes we listen to the history and we are premature into making a diagnosis. It may be right by default, but it may also be such that your assessment of the severity of the problem is a little excess and you end up prematurely medicating or over-medicating a child. And that's the issue that one needs to keep in mind. I noticed that Dr. Basu has put his video on. I would really like to listen to Dr. Basu's view, particularly from the viewpoint of adult ADHD, substance use and a kind of framework to enrich the discussion that we have already started.
Thank you, Dr. Seshadri, for this brilliant talk as usual. I mean, it's mesmerizing. But yeah, if I have about a couple of minutes with the kind permission from the chairs, while you have obviously used ADHD, as you said, as an exemplar for the main point which we have been trying to make, which I'm not too sure if it has been partly kind of lost on the audience. If we want to go into too much of nitty-gritty of the ADHD treatment, how long it should go on, etc., then it becomes like a talk on ADHD, which I believe was not really your aim. You used it as a brilliant example of how things needs to be seen in context in order to get its proper import. And that context means a lot of things. It's cross-sectional context, and this longitudinal trajectory, how things change, etc., etc. While listening to your talk, I mean, the same thing can hold for substance use and abuse and dependence, but that's a separate talk altogether, maybe some other day. While listening to you, I was tempted to go back while working on the computer to Leon Eisenberg. You know, Leon Eisenberg, who actually worked with the original person in this area, as we all know, and his famous and very controversial statement at his deathbed confession when he said that ADHD is so-called a fabricated diagnosis, or something like a fictitious diagnosis, etc. I don't know whether that's true or not, but I was reading his editorial in Acta Psychiatrica in 2010, and that was a beautiful, like all Leon Eisenberg's writings, they're an absolute pleasure to go through, you know. And this one says, "Were we all asleep at the switch? A personal reminiscence of psychiatry from 1940 to 2010, a 70-year journey." I'll just end with what he ended with. Interestingly and very coincidentally, exactly 50 years ago, in 1973, Leon Eisenberg writes, in 1973, I concluded a paper with a bold assertion, which I now repeat. So he repeats and he ends that editorial with this. This was one of the last ones before he died, actually. So he says, psychiatry at its best is a paradigm for the general medical practice of the future. Now, this may seem an outlandish claim, yet I believe, now this is the important part, which I think Saksena was trying to buttress or bolster, yet I believe it to be true because psychiatric practice deals with human distress in a context that must include the psychosocial, now this was said 50 years ago, psychosocial as well as the biological. There are no imperialistic aims behind this claim. Quite to the contrary, insofar as psychiatry is successful in clarifying the psychobiological basis of health and illness, that knowledge will pass into the domain of the generalist, and the psychiatrist will join other specialists in the secondary and tertiary cadres of the health system. In other words, we don't stand apart from others, but it is important for us to understand, appreciate, and bolster the role and the need of the context in human health as well as in human illness, whether it's physical or mental. Sorry, I must stop here now. Thank you. Thank you.
Thank you, sir, for your comments.
Yeah, I just wanted to, take off a bit from what Dr. Basu just said and actually add to a very brief comment that has been made on chat by Aditi, who says a trauma angle to ADHD. And indeed, this is the point that Dr. Basu was highlighting when he was quoting Eisenberg. Often we look at ADHD from the lens of a problem. We don't look at ADHD from the lens of vulnerability. And if you look at very young children with ADHD, who are social and exuberant, the kind of risk that they are exposed to, the larger context of risk, because they don't exercise the same kind of caution or they do not have the same inhibitory mechanisms that, let's say, an average or a usual child may have. So these bring up very important issues, therefore, of parenting or what we call as continuum of caretaking vulnerability, which can be either escalating or minimizing depending on how parents respond to a child who has emerging symptoms of ADHD. So, that's the kind of stuff that we need to speak about. I also see that there are a lot of comments which have come on recidivism and on criminality and so on. And I guess this is an indication for the curators of Thursday Musings at some point of time. Though mental health of under trial prisoners has been something that the National Human Rights Commission and many people have kind of studied, I wonder what depth this whole issue has been looked at. Were these people with ADHD, were these people who came from really vulnerable background? And I can certainly say, working with children in conflict with law as part of Samvad, which I have been running for some time, that most children who come into conflict with law come from brutal and vulnerable circumstances. A certain percentage may have ADHD, but they come from brutal circumstances of neglect, of abuse, of poor role models, of learning issues, of having dropped out of school, of emotional, physical abuse at home, of peer influence, of getting into substance use, and therefore making decisions when in the influence of drugs and so on. So yes, Namita, I have seen children with ADHD who are victims, and precisely for this reason, because we have never looked at children with ADHD from the lens of vulnerability. We always look at them from the lens of a problem. Over to you.
Yeah, sir, I think you have covered all the questions and made our work easy. So, as always, so inviting chairpersons for the final remarks, then we go to Tufanpati, sir.
Sir, Dr. B.R. Mishra, sir, is on the line. Okay. I think, thank you, sir. Once again, sir, thank you, sir, for the wonderful presentation, sir. You have covered in a very short span. You have generated a lot of interest, as we could see in the questions also. And sir, once again, concluding remarks would be, as clinicians, sir, we tend to see children, as you said, sir, from the point of problem, but rather than the point of problem, looking at the point of vulnerability, and looking ADHD as not only as a diagnosis, but as a complex psychosocial framework, and also understanding its complex interplay between the other comorbidities like OCD, other anxiety disorders, conduct disorders. So in this context, I think we have to really make a very wise decision before we come to a clinical diagnosis, look into the various complex interplay and the factors that are associated with this diagnosis. And at the end of the day, we are here to help our children at the best way possible. And also at the same time to alleviate the anxiety that may have in the parents also. So with this, sir, I again thank the entire organizing team, the participants who have joined us online, and all the dignitaries and senior faculty members for joining us all this time. And again, wishing a very happy new year to everyone. Good night to everyone, sir.
Thank you, Dr. Manoj. Over to Dr. B.R. Mishra. Bye.
Hello.
Sir is there. I think sir can give some concluding remarks.
Yeah.
Sure, sir.
I would like to thank Professor Sheshadri for an excellent presentation again, and the organizers for regularly conducting these kind of academic activities. Hope this trend continues in future also, which will be beneficial for the trainees as well as for consultants and all of us. And with this, I would like to thank everyone, and I hand it over to the moderators.
Tufan sir, your comments, please.
Thank you. This is a great beginning this year. First session by Dr. Shekhar Seshadri. Regrets. ये अगर Zoom meeting नहीं होता मैं सबको बोलता give a standing ovation, but most of the people are not on screen. Deserve it. The fantastic presentation, and all the issues involved have been taken up, but we need a strategy involving parents and the school authorities to have scope of sensitize them to have early detection so that intervention can be appropriate. A strategy has to develop for that. That is my submission. No questions. Submission for Sambal.
Amrit, over to you.
Thank you, sir. It was as good as it can get. In 2023, the first session, we had somebody else, but then we decided, the scientific team requested the speaker to give way to Dr. Shekhar Seshadri. He was more than happy because we wanted the best in the beginning of the show. And it was brilliantly attended also, more than 280, 290 logins, the peak of 220. And that was not expected because this is the holiday week that's still continuing. So thank you so much. You covered everything. A lot of questions which you yourself covered, and you also talked about pharmacology, and that was also good. So all in all, it was wonderful. There's some requests, and Dr. Ruma has requested you to sing a song to bring in the new year. I would also like to thank Manoj sir and my dear friend Dr. Biswaranjan. He has been connecting us from the ICU. And Biswa, all our prayers for your mother-in-law is very, very sick. We wish her a speedy recovery. Thank you for joining in from the ICU, and that speaks a lot about your dedication towards health and your respect for Dr. Shekhar Seshadri also, as well as to the musing team. Thank you to our viewers who are always with us. Thank you, Torrent. Thank you, IPS OSB, for giving us a chance. Thank you, Tufan sir, and Dr. Aleem. Aleem is the battery, the SA node. And he has been keeping it going with Dr. Tufan sir's guidance. I'm just the person who comes to say thanks. So people are asking, will he sing? Will he not sing? How many songs will he sing? What will he sing? Will he make us dance? So to you. Yes, he will sing. He will sing. He will sing. He has to sing. There's no option. Sir.
गम पे धूल डालो, कहा लगा लो, सांसों की डगरिया जिंदगानी है, तुम जो मुस्कुरा दो राजधानी है, ये हवा तेरी तेरी, ये सांस तेरी तेरी, बोलो समा सुहाना कैसा यारो, यारो नीलाम करो सुस्ती, अरे मस्ती का नाम तंदुरुस्ती, यारो नीलाम करो सुस्ती, नदी गीत गाए, झरना गुनगुनाए, गीत कोई तुम भी साथ गा दो ना, एक दीप राह पर जला दो ना, ये होठ सूखे सूखे, ये बाल रुखे रुखे, बोलो समा सुहाना कैसा यारो, यारो नीलाम करो सुस्ती, हमसे उधार ले लो मस्ती, अरे हस्ती का नाम तंदुरुस्ती, यारो नीलाम करो सुस्ती.
Thank you so much, sir. Thank you so much.
ये गाना शायद प्रेम पुजारी का है.
बिल्कुल सर.
लोकेश को सुना देंगे ये गाना.
और आप ही तो प्रेम के पुजारी है. आपका प्रेम के हम पुजारी.
Thank you, sir. So hope to see you.
Thank you so much.
Thank you. We need to invite everybody again to ANSIPS. If not registered, please register. We are all waiting with open hands. So thank you so much, everybody. Good night. Take care. See you again next week. Same time.
Thank you. Good night. Bye. Thank you for closing the meeting with your permission, Tufan sir.
Yes, please close.
Thank you, sir. Seshadri sir, once again, thank you so much. Bye.
Bye.